Hi, I'm John Cornelius, and this is the case for psychoanalysis, exploring the scientific evidence. So, I am a medical doctor who has some experience with psychoanalysis, psychopharmacology, and cognitive behavioral therapy. First, with psychopharmacology, I am a medical doctor who trained at UC Davis. I've worked as an inpatient psychiatrist and been a medical director of an intensive services program in Sacramento County for 5 years. And I've also worked as an outpatient psychiatrist. I do have some experience with medications, and about 80% of my patients are on medications of some kind. In terms of psychoanalysis, I am a psychoanalyst, and I've been trained at the Psychoanalytic Institute of Northern California. I'm a member of the International Psychoanalytic Association and adjunct faculty at the San Francisco Center for Psychoanalysis. I've had a psychoanalytic practice since 2006, and I'm instructor of record for the Introduction to Psychodynamic Psychotherapy course at the UC Davis Department of Psychiatry since 2011. In terms of cognitive behavioral therapy, while I don't conduct cognitive behavioral therapy directly, during my training I did work with Dr. Paul Munford, who was the director of the Obsessive Compulsive Disorders program at UCLA for 22 years, and worked with him at the Anxiety Treatment Center, a program that focuses on cognitive behavioral therapy, specifically those with OCD and anxiety disorders. I continue to work with multiple cognitive behavioral therapists, mostly around OCD symptoms, but have referred to them occasionally for other issues in the past. Now, here's the problem. During the teaching of my course at UC Davis, the Department of Psychiatry, I recognize that the psychiatric residents are exposed to multiple different treatments. However, I recognized a common misperception, and the misperception is that medications and cognitive behavioral therapy have tons of evidence and conclusive efficacy, while the misperception again is that psychoanalysis has no evidence or no efficacy. And when I asked the residents why they believe this, they were pretty frank in saying that this is what they were being taught at the time. So to me, this created a challenge. And the challenge is to make a case based on scientific evidence for the use of psychoanalysis. So the goal of this presentation is to show that the scientific evidence base for psychoanalysis is significant and robust, that it shows efficacy, and that it distinguishes itself from other treatments. So the first question is how do we do this, and how do we study treatment effectiveness? So the main way we're going to do this in this talk is to look at scientific methods of testing treatment effectiveness. Now, in general, this is done in two different ways that I'm going to talk about. One is through individual studies. Individual studies directly collect, examine, and report data. So a classic example of this is the randomized control trial. The randomized control trial takes a group of people, separates them randomly into various groups. It does different things to the different groups, and then it compares the different groups to try to determine some outcomes. Okay, now this is different than a meta-analysis. What a meta-analysis is it takes data from multiple different studies, and it tries to take the data to integrate and compare findings. And it still tries to compare different groups. Now, the advantage of a meta-analysis theoretically is that it has a broader amount of data to draw from. So one way that meta-analyses try to tell us or help us understand which treatments may be more or less effective is it tries to generate a number commonly referred to as an effect size. And the effect size is the difference between treatment groups expressed in standard deviation units. So an example of this is if we were to compare treatment A versus treatment B on a depression scale and ended up with an effect size of 0.23, it means that patients with treatment A did 0.23 of a standard deviation better on that particular scale than patients with treatment B at that point in time. Okay? Now, while there is a lot of debate about what effect sizes actually mean and how big of an effect size actually matters, these are some numbers that I got from a statistical textbook. And what it says is, in general, A large effect size is a number around 0.8. A medium effect size is around 0.5. And a small effect size is around 0.2. And again, these are general numbers. It doesn't mean that small effect sizes aren't working, but it just means that their effect is smaller in this particular study. Now, an important thing to remember here is that numbers don't think, and that people do. And so even though these numbers are giving us, even though the numbers are generated and give us some information, we still have to put them in context to understand what the numbers actually mean. So let's get started here. So first, treatment 1, antidepressant medications, something that I use quite a bit of. And if we look at the rate of antidepressant use, here are some numbers from the National Center for Health Statistics. And it showed that antidepressant use increased by 400% between the late 80s and early 90s to the mid and later 2000s. And by the end of this data collection, 1 in every 10 Americans was taking an antidepressant. 1 in every 10, making it one of the most common treatments in the United States. So let's look at some of the data here. And this is a study that was generated by Eric Turner and published in the New England Journal of Medicine in 2008. And what he did is he collected all the data from the registered FDA antidepressant studies between 1987 and 2004, which included 74 studies. And he collected all the data and looked at some of the numbers. And here's a little bit of what he found. First, if you look, you'll notice that there were 48 published studies, most of which were positive, and there were 26 unpublished studies, most of which were negative, making a total of 74 studies. Okay? But when we look at all 74 studies, we actually find that 48% of the studies were negative. 48% showed that the medication that was used could not beat placebo or its comparator. Okay, that's almost half. And then if we look at the efficacy of antidepressants, the overall efficacy was 0.32. And that's from all the studies between 1987 and 2004, including 12,564 patients. So here's another study. It's the STAR-D study. And in my mind, the STAR-D study is still the largest real-world scientific study of depression treatment to date. It was funded by the National Institute of Mental Health rather than drug companies. And they tried to make the study real-world, which means they did not use extensive exclusion criteria to kind of limit the patient population. It included over 4,000 patients in 41 different centers across the United States. And this is basically what they did, is you entered the study and they started the first drug, which is citalopram or Celexa. If that study worked, if that medication worked, you just stayed in that position in the study and you just stayed on the medication. If it didn't work, you went on to step 2, tried something else. If that didn't work, you tried step 3. If that doesn't work, you try step 4. And if that doesn't work, you go to step 5. Okay? Now, an important thing to remember here is that in step 2, right here, there is a cognitive therapy branch of the STAR-D treatment. Okay? So they did try to look at cognitive therapy in this study. And when you look at the end of study point for STAR-D, the number looks really great. So they did a series of depression scales at the end of the study to try to judge how depressed a person was, and 68% of people at the end of the study were in what was considered full remission, which means they scored low enough on the depression scales that they were considered in remission. 68% is a great number, and it actually is a very hopeful number that shows the power of the antidepressant treatment regimen. So here's the next group, cognitive behavioral therapy. For those who aren't familiar with cognitive behavioral therapy, here's a thumbnail. It's a short, scripted, problem-oriented method of psychological treatment with an emphasis on practical coping skills. CBT often treats thoughts, behaviors, and feelings as things to be consciously manipulated. CBT often has a classroom atmosphere where the therapist is directive in a teacher role, and overtly instructs the patient how to change thoughts and feelings in manualized and concrete ways. Now, here is a review done by some big names in cognitive behavioral therapy where they collected meta-analysis data from multiple different studies. And what the data shows here is pretty good. So for major depressive disorder, if we compare cognitive behavioral therapy to those in a waiting list who are kind of waiting to get treatment, cognitive behavioral therapy does better than those on the wait list by 0.82. So it has an effect size of 0.82. When you directly compare CBT to antidepressant medications, SSRIs specifically, you get an effect size of 0.23. Similarly, with general anxiety disorder versus the waitlist, you get 0.82. For panic disorder, CBT versus the waitlist, 0.91. Social phobia, CBT versus the waitlist, 0.93. Obsessive compulsive disorder, pre versus post. So what they did here is they compared those with obsessive compulsive disorder, how they were doing before the treatment compared to after the treatment, and they had a very significant effect size, 1.3. Similar with PTSD, CBT versus the waitlist, 1.36, and for chronic pain, CBT versus the waitlist, 0.4. So good numbers. Here's some STAR-D data where they use cognitive therapy, and this is in level 2. And so people had been taking citalopram, and it had not been effective, and so they moved to step 2. And in this graph, they augmented, which means they added cognitive behavioral therapy, which is the red line, or they added another medication, which is the blue line. And you see this is how they did, and basically people are doing better and better and better through the study over here. And here's where they did a switch. And when they switched, as in stopped the citalopram and switched to a new medication or switched to CBT, here's how they did. And you again see more and more probability of remission as time goes on, weeks in the treatment. So if we take step 2 overall, you see that the switch to cognitive behavioral therapy ended up with a remission rate of 41.9, and augmentation with CBT with medication, you ended up with a remission rate of 29.4, both of which are pretty good numbers, although I'll tell you the CBT people who I talked with and my reading of the data showed that they were actually somewhat disappointed with these numbers. So let's go on to look at psychoanalysis. For those not familiar with psychoanalysis, here's a very brief thumbnail. But psychoanalysis is a psychological theory and therapy that understands the mind as being composed of conscious and unconscious elements. Work with both is required for psychic change. The therapists tend to have an unscripted, explorative stance. This includes attention to past and current relationships, even the relationship with the therapist. Unconscious material such as spontaneous gestures, sudden emotional reactions, and dreams are given special attention. So, first, to just directly challenge the idea that there isn't any evidence for psychoanalysis. And by the way, when I say psychodynamic psychotherapy, for the point of this talk, I'm going to use them interchangeably. There's always a debate about the differences, but again, I'm going to use them interchangeably in this talk. But here's a study done by Gerber and published in the American Journal of Psychiatry in 2011, where they actually reviewed the scientific evidence base around psychoanalytic psychotherapy. And what they did is they taught 5 independent evaluators, and they reviewed the evidence base. So the independent evaluators, some who were psychoanalytically oriented and some were not, all agreed independently that 63 studies of psychodynamic psychotherapy were considered statistically, empirically, and scientifically sound. Okay, and here's some of the data of what they found. So they broke up the study into active comparators, which means psychodynamic psychotherapy was being compared directly to, say, antidepressant medication or cognitive behavioral therapy or some other active thing. And here's an inactive comparator, where psychodynamic psychotherapy is being compared to a wait list or some kind of attempt at placebo, although that's very difficult with psychodynamic psychotherapy. And what you found is when you were comparing them against active comparators, 28 of the studies found that they were the same as the active comparator. The end of study data was the same. 6 said it was better, 5 said it was worse, so most of them were the same as the active comparator group. If we look at the inactive comparator, we see that the majority, or 3/4, were superior to the inactive comparator. Okay, so here's those numbers. This slide is just to show you that how these numbers kind of stack up against that Turner antidepressant meta-analysis. And again, for the antidepressants, the SSRIs, we saw 52% positive, 48% negative against placebo comparator. And here's the data for the psychodynamic studies. Okay. And so let's look at some effect sizes for psychodynamic psychotherapy. The first study is from the Cochrane Library, published in 2006. The Cochrane Library is a respected independent organization that does reviews of all sorts of medical treatments to help improve evidence-based decision-making. And what they did is they looked at 23 randomized control trials of over 1,400 patients for short-term psychodynamic psychotherapy compared with controls. Okay. And this is their end-of-study effect size. So at the end of the study, they found general symptoms versus the wait list, which I honestly don't know what exactly that is. They found an effect size of 0.97. For somatic symptoms, so those are physical symptoms versus the wait list, they found an end-of-study effect size of 0.81. Depression symptoms versus the wait list, 0.59. Anxiety symptoms versus the wait list of 1.08. So here's the Harvard Review meta-analysis. This one differs from the previous one in that it looks at long-term psychodynamic psychotherapy, which is averaging 150 sessions. And they broke it up into mild and moderate symptoms, which included anxiety and depression symptoms and severe personality disorders. And again, for mild and moderate symptoms, they found an end-of-study effect size of 0.78, and severe personality disorders, 0.94. Okay, and here is another study that was published in the Journal of the American Medical Association in 2008, directly comparing long versus short-term therapy. Long-term therapy won out, 0.65. And if you compare pre versus post, so how somebody is doing before the treatment versus the end of treatment, you see an effect size of 1.03. Okay, so here is again just stacking up the different graphs. Here's cognitive behavioral therapy and their effect sizes. Okay. Here is the antidepressant effect size, and here's the psychoanalytic or psychodynamic psychotherapy effect sizes from their studies. Okay. Now, what you'll see by looking at these numbers, I think, is that there doesn't seem to be massive difference. Everyone points out that the antidepressants do have a lower effect size, so that is something. But if you compare the others, the numbers are actually ballparkish within the same grouping. There's not a absolute home run clear winner of one over the other. So this brings up a very honest and reasonable question that is brought up all the time. And the question is are all treatments equivalent? Because if they are all the same, what difference does it make? So for example, why not use pills? Because pills are very easy and you can follow a formula to give pills for patients. You don't need a lot of specific training. You can get a medical degree. Any primary care doctor can follow a formula. Another question could be, why not just use cognitive behavioral therapy? Because it's very scripted and it's time limited. It should be easier. So why not use cognitive behavioral therapy instead of these long open treatments that psychodynamic psychotherapy seem to offer? And these are really good questions, and they actually need to be addressed. So let's look at things a little bit more closely here. So what I'm going to bring up here is the concept of an end-of-study data versus longer-term results. End-of-study data is data that's collected at the moment the study ends, right before the study ends, actually. And most studies are somewhat short. So they could be on the order of a few weeks to a few months, and it tells you how the person was doing at month 6 when you started the treatment at time 0. And so those really reflect short-term results. And there's a lot of value in short-term results. We'd like to know that treatments work relatively quickly or how long it takes for them to work, etc. So it's important data. However, let me put forward, there's another area that people are really concerned with, and that's long-term measurements. It's nice to know how somebody's doing at 6 months, but it's also really valuable to know how they're going to be doing a year later, or 6 months later, or a year later, or 18 months later, and so on. And I think most people really would like to know long-term measurements. Is this going to help somebody a year later? Are they going to be in the hospital yet? Less. Are they going to use less resources? And these are things that actually have been studied. So let's look at some of these. So here's antidepressant medications. Here's the STAR-D data. Again, 68% were in full remission at the end of the study. And one thing they did is they did what's called naturalistic follow-up. So naturalistic follow-up is where you simply call up the people later. So at the end of the study, people were told to continue on their medications. A lot of times they were actually continued to be followed in the same clinics, so they were seeing the same doctors, the same group of people in the same clinics, and they're saying, we're so glad you're feeling better. We really recommend that you stick with what you got, and if things go wrong, of course, see your doctor. But the study's over. Thank you very much. But what we will do is we will call you occasionally to see how you're doing over time. And this is that data. And again, this is the different steps. Step 1 through step 4 is what they measured here. And what you see is for those who were in step 1, as in they started the citalopram and that worked, almost instantly from the end of the study, people start relapsing. And by the end of the year, 40% of people had relapsed. I know on this graph that I actually got from their website, it looks like a little bit more than 40%, but they said cumulative 40% of people had relapsed with step 1. Here's step 2, 55% had relapsed. Here's step 3, 65% had relapsed. And here's step 4, 71% of people had relapsed at the end of the year. Okay, so almost immediately after the end of the study, boom, people start relapsing. And pretty significant numbers of people relapse. Okay? Now another interesting number here is the average months to relapse, which they measured. And you look, and the average months to relapse was 4.1 months. In step 2 was 3.9 months. In step 3 it was 3 months, and in step 4 it was 3.3 months. So this was how long it took the average person to relapse. And again, it was on the order of 3 to 4 months. Here's another study basically showing the same thing. Over time, with the medication groups, here's the placebo, here's the medication groups, and you basically see over time people just start relapsing. Okay, and here they say the percent not relapsing, but over time, pretty soon people just start relapsing. Okay, here's another study that says the same thing. Study that says the same thing. Basically, it's kind of flipped over. So this is the percent not relapsed. And basically, more and more people start relapsing. Now, again, it's not the same as the placebo line, okay? But it sort of parallels the placebo line of rate of people relapsing to depression. Now, I have to say clinically, this is a very common problem with antidepressant treatment. Medications regularly stop working, and they regularly work for limited time periods. It's extremely common. It's very difficult. It's given different names, poop out, drat. There's many elaborate explanations for this effect, but I've never seen a completely satisfactory one. But it's real. It happens. Any psychiatrist or people with experience in this area will tell you that. So let's look at cognitive behavioral therapy. Here's the study. There actually is a cognitive therapy arm in this group, which is the circles, and they're doing better, clearly, than the placebo. But if you notice, it's sort of following a parallel course here again of more and more and more people relapsing. If we look at the STAR-D data with CBT, I actually couldn't find a study that specifically addressed CBT, which is actually sort of interesting about relapse rates. Their data, my understanding of the data is it basically followed the same data as everyone else, as all the other treatments, which was actually disappointing for the cognitive therapy folks. But it showed that step 2 Again, you had the same relapse rates as the other ones, and the average months to relapse was the same as the other treatments. So here's some more data with cognitive behavioral therapy over the long term. This is a study done by the economic research arm of the National Health Service in Scotland. This was done in 2005. What they did is they had 10 previously positive cognitive behavioral therapy trials that had been done in Scotland. And they asked the question of how are the patients doing 1 year later, 2 years later, 5 years later, I think as long as 8 years later after the studies, to see how people were doing over time. And because of good record keeping in Scotland, they were able to actually just track the individuals afterwards, see how well they were doing, see how their complaints were doing, see whether they were saving money for the health system, seeing if cognitive behavioral therapy was sort of earning its keep economically and otherwise. And this is what they found. Here's some quotes from the results section. The positive effects of CBT found in the original trials were eroded over longer periods of time. No evidence was found for an association between more intensive therapy and more enduring effects of CBT. The cost-effectiveness analysis showed no advantages of CBT over non-CBT. Again, by looking at these studies, the cost-effectiveness analysis showed no advantages of CBT over non-CBT in these 10 studies over the long term. Here's something from the conclusions. Psychological therapy services needs to recognize that anxiety disorders tend to follow a chronic course and that good outcomes with CBT over the short term are no guarantee of good outcomes over the longer term. They could not find a link between how people were feeling over the short term with CBT and how people were feeling over the long term. They could not find a link. So here's the Swedish experience. So in Sweden between 2008 and 2012, the government got very much into CBT. And they used CBT as an essential part of their treatment programs for people who were kind of on the welfare system within Sweden. And they initiated this program to try to reduce absenteeism and welfare programs, which were kind of referred to as sick days, due to a variety of physical and mental disorders. And each year in this program, 40 to 50,000 people were treated. 40 to 50,000 people. And more than 80% were psychiatric patients. And 90% of these patients were treated with CBT in the program. So 90% were treated with CBT. So the Swedish government in 2011 commissioned a medical university to study the results. And the results showed those who received CBT had actually a slower recovery rate and increased sick days than comparable controls with treatment as usual, minus the CBT. You know, paradoxically, the government thought that this was a success and continued the program. And then several years later, they did another study. And the second study showed similar results. Out of those who were sick listed, those who received CBT did not do any better than the treatment as usual matched controls. No economic benefit was found for doing CBT in either study compared to the treatment as usual group. So here's Scott Miller from the Center for Clinical Excellence. The latest issue of Sociomen, the official journal for the Swedish social workers, reported the results of the government's 2 billion Swedish crown investment in CBT. The widespread adoption of the method has had no effect whatsoever on the outcome of people disabled by depression and anxiety. Okay, so let's look at psychoanalysis. My guess is a lot of you see where this is going. There is evidence that psychoanalytic benefits actually increase over time. So let's look at some of that. So this is that Journal of the American Medical Association study that was comparing long versus short therapy. This is the end of treatments data. What I didn't mention before is that they actually have another piece of data 23 months post-treatment. So this is almost 2 years later. And you look and you see the people receiving long-term therapy, end of treatment are doing effect size of 1.03. 23 months post-treatment, they have an effect size of 1.25. So get some more data. Here's the Cochrane Library meta-analysis. end of study results that I went over earlier. Here's 9 months post effect size. So 9 months later, if you look at the patients, you see again, increase, 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 increase. People are doing statistically better as a group 9 months after treatment than they were doing even at the end of study point. So here's an individual study, a small study done by Fonagy and Bateman, who created a treatment method called the mentalization-based therapy, which was designed specifically to treat patients with borderline personality disorder, one of the most difficult conditions to treat in mental health. And it was an intensive program. They developed an 18-month psychoanalytic partial hospitalization program. And then they randomized patients with borderline personality disorder to the hospitalization program versus normal psychiatric care. Here's what they found. Here's some of what they found. So this is 18 months after treatment. 18 months after treatment, the controls. So this is treatment as usual, which actually included CBT, supportive therapy, psychiatrists, etc. And you see 18 months after treatment, 13% of people no longer met criteria for borderline personality disorder, which is great. But those in the mentalization-based treatment, 18 months after treatment, 57% no longer met criteria for borderline personality disorder. Okay, so that's a good piece of data, 18 months. Now, Fonagy and Bateman actually upped their game, and they measured the data again 8 years after treatment. 8 years after treatment, we go from 57% no longer meeting criteria for borderline personality disorder to 87%. 87% of the patients no longer met criteria for borderline personality disorder, in direct contrast to controls, which maintained about a 13% no longer meeting criteria for borderline personality disorder at 18 months and 8 years. I don't know about you, but this is a shocking piece of data. According to conventional thinking about borderline personality disorder, it's unclear if this is even possible or even should be possible. But this is the numbers that they found. So here's one more study, the Harvard Review end of study data. Mild, moderate symptoms, severe personality disorders, or severe personality symptoms, sorry. Long-term, 150 sessions. Here's what they found long-term. So short-term, 0.78 effect size, anxiety and depression. Long-term, 0.94 at 3.2 years, long-term effect sizes. Severe personality symptoms, 0.94. Long-term effect sizes, the effect size basically held and improved slightly at 5.2 years post-treatment. So here is some of the graphs all put together showing the different studies, showing some long-term after-study data for psychodynamic psychotherapy. And let me just summarize here. So for antidepressant medication, the pros are there are a large number of studies. We have a lot of real-world positive data. It's a very common and accepted treatment. It is easy to treat large numbers of people. However, the downside here is that antidepressants actually have a low overall effect size. There are many negative studies that show it doesn't beat placebo. There are significant relapse rates, and there are treatment side effects. Cognitive behavioral therapy, there's pros. There are good end-of-study effect sizes. They have short durations of treatment. It's very structured. It has social acceptability, and it's easier to treat large numbers of people. However, there is a significant downside that large-scale attempts to conduct CBT have had very questionable long-term outcomes. And there have been significant relapse rates noted in several of these studies. Here is psychoanalysis or psychodynamic psychotherapy. Pros, they have comparable end-of-study effect sizes. There's evidence for persistent, even increasing benefits over time. And there's evidence of long-term effectiveness even in severe disorders such as personality disorders. Now, the downside of this treatment type is that psychodynamic psychotherapy tends to have longer treatments. It also tends to be unrecognized at this point, and it's hard to treat large numbers of people. So, thank you. I hope that I've shown that the psychoanalytic evidence base is significant and robust, that it shows efficacy, and that it can distinguish itself